advocated for myself. I really liked cardiac. I really wanted to have a lot of experience there. So I just told my clinical coordinator, the chief anesthetist, that I was really interested in hearts and asked to be scheduled there. So she did pretty routinely every week. I was up there in the heart room. So I got to build a really good rapport with all the cardiac anesthesiologists there. And I really just used that to my advantage. I showed up on time, I showed up prepared, eager to learn, and I just kind of put bugs in the ears of every single doc I worked with, like, hey, I really love doing hearts. It'd be really great if you guys got CRNAs up here. And I just constantly advocated, and that's all I did was mention it again and again and again, so everybody knew I was really interested in hearts. So when I graduated, I started there in February. A month into my CRNA career, we had an opportunity where they needed to start a heart, and there wasn't a physician available, but I was free. So the anesthesiologist who was in charge that day was one that I had done a lot of hearts with as a student, so he knew I was really interested in hearts, and we worked together a lot when I was a CRNA, so he and I had a really good rapport. And so he thought of this great idea to have me do the heart. So he came and he asked me if I would be willing to do it, which of course I said yes. But on the inside, I'm like really freaking out because this is like a really big deal. I know that no CRNA had ever done it, but on the outside, I maintained my student mentality of fake it till you make it. So I acted like I was doing this guy like a huge favor. I was like, yeah, I guess. I'll do a heart, but like inside I'm like, oh shit. So I did the case, everything went really well. It was awesome. It was a really great experience. And then what made it even better was that I knew what a big deal it was because, as anesthesia providers, we know the constant political fights we have to go through to fight to the extent of our practice and to the extent of our license. But for everybody else in the room who was involved with the case, for them to be encouraging and for them to realize what a big deal it was really awesome. The entire OR staff was like high-fiving me and they're like, oh my God, this is awesome. You're the first CRNA in this room. After the case was over, the anesthesiologist pulled me aside and was like, you and I just made history today. We just proved to all these old docs in our group that you guys are capable, you guys can do these cases. There's no reason you shouldn't have been in these cases from the start and all this stuff. I even went home that night. I was getting text messages from the other docs in our group, like congratulating me. I was getting messages from nurses who don't even work at Baptist anymore. So like news had just like traveled all over the like cardiac world in Jacksonville, basically congratulating me. And it sounds so silly, like saying that to a group of people who do anesthesia and do hearts, because that's normal. Like CRNA should be doing hearts, but at Baptist it wasn't normal. It was a really big deal. So the cherry on top was that the surgeon went home that night, and he knows my mom, and he knows that I'm her daughter. So he went home that night and he texted my mom and said, hey, your daughter just did a heart at Baptist. She just made history. She did a really great job. You should be really proud. So I thought it was pretty cool of him to go home and do that. And so whenever I transported the patient up to CVICU, that's my background. I used to work CVICU at Baptist, so I knew a lot of the nurses who I was delivering this patient to. They all saw me delivering a patient to them. And for the CVICU nurses who have worked there for 10, 20, 30 years, they've only ever received a patient from a physician anesthesiologist. So not only receiving a patient from a CRNA, but from a CRNA that they know. And I worked there, so I know exactly what they like, and you better believe I brought that patient up looking pristine. I mean, I changed that cordis dressing, I labeled, I dated it, I timed it, I taped the pacing terminals exactly where they like it, my lines were pretty, everything was labeled on both sides, not with smudgy pen, but with like pretty Sharpie, like I had my shit going on. And so I delivered this patient with a little cherry on top, so I proved to them that not only are we capable, we're very competent, and we can do these cases. This doesn't need to be a physician-only case. So I tell you that story not to brag or to boast or to make myself seem like a big deal, because I'm not. I sat in the same seats. I graduated from this program, and you're going to do the same thing. You're going to graduate from this program, and you're going to go into whatever group you go to work for, and you can make an impact within your group too. So here I was this brand new baby CRNA. I had 1 month experience, never done a heart as a CRNA before. My only experience was a student, and I got this really great opportunity. So did I change practice at Baptist? Nope. Did I change the culture? Nope. They still don't have CRNAs in those rooms. But did I impact culture? Absolutely. Did I push a barrier? Absolutely. Did I get the group talking about it and making strides in the right direction for our profession? Absolutely. And did it take me like gathering all my CRNA friends and marching into an office with pitchforks and like making demands? Nope. It was a very simple, subtle, I just expressed interest. People knew I was interested in it. An opportunity presented itself. I went to work every day as a CRNA. I did the best job I could do, and that's how it happens. So let that be motivation for wherever you go to work, that you definitely have the ability to impact the culture at your practice. You don't have to get stuck in the mentality of, well, this is how it is and this is how it's always done, so this is what we do. You guys have the ability to speak up and advocate for yourselves and advocate for the profession. That's something.
Awesome. And then the next day you were in the colonoscopy suite.
No, actually the very next day I got to do another cardiac case, a structural heart case, which again was a physician-only case.
Nice.
And a really big to-do was made of it. I'm talking the president of the hospital. They had this big powwow because I was scheduled for that case, and they still let me do the case, and everything went well. So it's just like, it's kind of a domino effect. You do a good job in one case, and then they're like, oh, okay, they're not idiots. They can do this job, and it just kind of keeps rolling.
Can't blame them for being idiots. You've got to teach them slowly. So with that, I will hand you guys over in the capable hands to Dr. Wilson, and enjoy Ask Questions at your leisure.
So when Dr. Papalotti asked me to do this lecture last year, I thought really long and hard about what I would have wanted when I was a student. And I remember when I was preparing for my first heart case, I spent the entire weekend at Starbucks reading every single reference material I could think of. Big Miller, Baby Miller, I'm YouTubing, I'm calling my mom, she works in the CVR, I'm calling her, asking her like surgical questions, I'm texting all my SRNA buddies and asking as many questions as I could, so that on Monday morning when I went in for my first case, I was like, I got this. I am so prepared. I knew every textbook thing there was to know, and I walked in feeling like I was really prepared. But then when I actually went into the actual case, I kind of had like a deer in headlights look the entire time, and I realized that I kind of got lost in the weeds of all of the cellular level of learning everything there is to do about cardiac anesthesia. So when he asked me to do this lecture, I didn't want to, I remember what psych to have guest lecturers, and I hated it, and I didn't want to stand up here and be hated. So I also wanted to do, I don't want to just stand up here and read to you Big Miller. This in no way is going to take the place of you guys reading whatever assigned readings you're supposed to read. I'm not going to dive in that deep. I'm not going into the cellular level of anything. I'm not going to talk about hemodynamics. I am going to graze the surface, and I wanted this to be a very practical, how to kind of step-by-step guide of exactly the flow of cardiac anesthesia and exactly the flow of what to do if you're in a case. So hopefully tomorrow, if you're scheduled for a case, you won't be total deer in headlights. So I'll breeze through a lot of it because I don't want to be here all day, and you can read all on your own. So as many things as you need to know for these cases, the really good part about hearts is that it's pretty routine. It's pretty copy-paste. There's a lot of repetition in it, and it's separated into three very distinguishable categories. You've got pre-bypass, on-bypass, and post-bypass, and that's it. And then, of course, your pre-op and your transfer to CVICU, just like any other case. So, yeah, cardiovascular disease is big. There's a whole bunch of pre-op evaluations in different textbooks, whatever you read. But the basic goal of pre-oping these cardiac patients is to see how sick they are going in to cardiac surgery, because that's going to be a big indication of what you're going to do when they come off pump. So basically, everything you're doing in the pre-op period is to see how sick they are going in so that you know how hard it's going to be to get them off pump. Common sense, the sicker they are going in, the sicker they are going to be coming off pump. So you're trying to get an idea of exactly how sick they are, what kind of comorbidities they have, what's their baseline EF, what's their baseline overall health status, how well are each of their comorbidities managed, because if they are poorly managed, non-compliant, A1C is 9, they're smoking, they're morbidly obese, you know that they're going to be a lot harder to come off pump. And so that can kind of give you an idea of what drugs you want to have, not only in the room, but like prepared, ready to go. So that's the whole point of pre-op. Again, y'all read this yourself. A big question you want to ask is their functional exercise tolerance. You should really just get in the habit of asking all your patients this. I ask everybody from lab appies to OB. That's just my general question is, you can make it small talk too. You know, hey, what do you do for a living? What do you like to do for fun kind of thing. Depending on the surgical procedure that they're having done is going to increase your morbidity as well and make it a different challenge for when they come off pump. If you're having just a bypass, that's going to be simpler than if you're having a valve and a bypass or 2 valves. So that's going to play a part into what you're going to want to plan for when they come off pump. Again, just different risk factors to look for. Look at their EF, their stability of symptoms. Is it chronic? Is it stable? Et cetera, et cetera. Just know how big the problem is and how bad it is. One of the big things you want to look for is their baseline EKG. A lot of times these patients go into all sorts of arrhythmias. If they have a baseline irregular rhythm, you can anticipate going into it, coming off pump too. They're going to have some sort of AFib, especially if they have a history of it. And then you also always want to look at their baseline echo. You want to know what their baseline LV function is. If they have a poor floppy heart going into it, and then you arrest it, you put it on bypass, and you just mess up their entire heart, it's going to take a lot more effort to get them off of pump and get them stable to transfer to CVICU. Every patient should have a cath. Take a quick look at that. Know which vessels are affected if they're going for cabbage, and know what part of the myocardium that is that's affected. So here's a good tech. Have you guys had tech class? No. Oh, okay. You're going to say no.
They always say that.
So I'm going to breeze over this. You guys can just use this as kind of a study guide. If there's anything I talk about in this lecture, again, I'm not going to go into detail about it, but use it as a study guide that maybe that's something you should review. So obviously you're going to need EKG and defib pads. All these patients are going to have a pre-induction A-line. When you talk about massive blood pressure swings, this is the case you're going to see them. There's constant manipulation of the great vessels. They're leaning on the heart. They're picking it up. They're moving it around. And you can have a blood pressure of 120 and then a pressure of 30. It happens like that. So an A-line is absolutely necessary. One of the big considerations you want to think about is whether or not they're going to take the radial artery as a graft. If they're going to do that, you obviously would not cannulate that side. And I think usually those patients come in with like a limb alert bracelet or a sign on the bed, like no blood pressures, no sticks, whatever. Everybody's going to have central venous access. You're going to be giving large amounts of fluid. You're going to be giving vasoactive drips, lots of blood draws, ACTs. And sometimes you can use the swan gains as well. I know the literature is very controversial about that. I think some people think it's antiquated. Some people think it's necessary. You can get a lot of really good information from a pulmonary artery catheter or a swan gans. Has anybody worked CVICU as a nurse prior to? Okay, so you guys have a lot of experience with that if you worked at a facility that they routinely use that, but not everybody does it. Not every facility does it. I remember as a student, I think like Flagler, they don't use it, and they think it's like absolutely archaic that some other facilities still use it. And just like everything we do, nothing that we do in anesthesia is benign, so of course there's risks with floating it. You want to know what your absolute contraindications are before you put in a swan if you choose to. You're going through the right side of the heart up into the pulmonary arteries, so obviously anything impacting your way through that route, you're going to want to avoid putting one in. All patients will have a TEE after they go to sleep, and that's to look for just the overall contractility, the overall squeeze of the heart, and to check for AI because that's important for cardioplegia, and we'll go over that later. Patients should have a cerebral oximeter. You want to make sure that we're perfusing the brain on bypass. You're going to use a BIS. If you guys haven't learned yet, one of the big cases that are at an increased risk of intraoperative awareness is OB trauma and on bypass. And then every patient will have a Foley. I think they usually keep those for 2 days. Not that that's relevant to us, but everyone's going to have a glucometer, ABG, ACT, know what the institutional policies is there of who runs it, where it is, how it works, all that. Underbody warmer, these patients are prepped from neck to toe, so obviously don't waste your time pulling out a bear hugger, that'll just go wasted. And also don't pull out a temp probe if you're putting a swan in. I definitely did that as a student. I felt like a total idiot because I shoved this esophageal temp probe in, and then I'm like, oh, it's right there. I'm like, you're swan. And a fluid warmer. Everybody's gonna have a fluid warmer. So when you're getting your room ready, there's going to be so many drugs, so many monitors, all these things. You want to be totally organized. In these cases, when things go wrong, they go wrong hard and they go wrong fast. So you want to know where everything is. You don't want to be fumbling around. If you know you're going to be using a drug, have it prepared, labeled, ready to go. Have your drips prepared, labeled, ready to go. Know which pumps you're going to use. Just have everything together. You want to know where your stuff is when things go bad. When you're setting up your room, you're just going to check and double check everything. Like I said, know what the institutional policy is for your ACTs and ABGs. Do you need to know how to operate that machine? Because I definitely don't. If somebody told me to run that, I'd be like fumbling with that. I don't know. So if you know that you're responsible for drawing it and for using that machine, make sure you know how to use it so that they're not staring at you waiting for this lab value when you don't even know how to use the machine. Make sure you have your Alaris pump and all your channels, or whatever pumps you guys use. You have pump tubing. Just kind of go through everything in your head of everything you may possibly need. Where is it located? How do you use it? When you get your pacemaker, make sure that not only you have a pacemaker, but it has batteries. I learned that the hard way because I really felt like an idiot when he was like, okay, go ahead and pace. And I was like, oh, wait, can I get batteries? It's embarrassing. You're going to need lots of drugs for cardiac cases. I think that probably goes without saying. But in terms of which specific drugs you use. I think it just varies based on institution, based on cardiac surgeon's preference, based on anesthesia provider's preference, but you basically want to have at least one of each of these different categories of drugs because you want to have some sort of vasopressor, some sort of inotrope, some sort of dilator, antiarrhythmic, and then of course every patient's going to have heparin, protamine, and antibiotics and antifibrinolytic. All of these patients should maintain their normal long-term medications. They should hopefully come to surgery as well optimized as possible, with the exception of anticoagulants. They're going to be stopping those prior. So when they are ready to roll back, these are really big cases. These patients are usually very scared. You have a lot of stuff to do when you get in the room. A lot of monitors are going to get put on. You're going to do a pre-induction A-line. So you want to be liberal with your Versed, but not so much to where you're having to maintain their airway when you get in the room. So if you always err on the side of caution, you can always give more. So maybe before you go back, if it's a young, healthy guy, you can give 3 of Versed, and then when you get in the room, give another 2, whatever. But I think a usual goal would be to get like 5 milligrams of Versed in pre-induction. So once you get in the room, you're going to put on all the monitors, all the EKG pads, all the defib pads. There's a gazillion of them. Put your circuit on, pre-oxygenate them. Do they need more sedation? Did you get all 5 of Versed in? Can they tolerate some more? Go ahead and give some more. You can give some fentanyl. Make sure they're nice and comfortable. You don't want them remembering this really scary part. Excuse me. You're going to place your A-line, and then you can get ready for induction. So a little overview about anesthetics. All of them are going to decrease your SVR. They're myocardial depressants, so you're going to want to be judicious with your induction. These aren't the patients that you just want to stand 200 of propofol in. You want to tailor your induction drugs based on what the patient needs. If they have a really great EF and they're young and healthy, and this is kind of an incidental finding, then they can probably tolerate 200 of propofol. But if not, then you want to just use higher opioids and maybe some etomidate or maybe some ketamine. Whatever your recipe du jour is just individualize your care. You also want to avoid nitrous on this. I love nitrous. I use nitrous all the time, but you don't want to use them in this because it's going to increase your PVR and that's going to affect your right heart pressures. And then this is also one that you want to make sure that they are well anesthetized before you DL. So one of the biggest things that we can impact as anesthesia is to maintain myocardial protection by not allowing them to get tachycardic. So if you go to DL a patient who isn't really well anesthetized and you have all of that stimulation, you're going to get a big response and they're going to get really tachycardic, and that's going to increase your myocardial oxygen demand. And these patients are already ischemic as it is, so you're just kind of worsening the problem. So this is one you want to make sure they've got adequate narcotic on board, they've got adequate hypnotics on board. I think at Flagler, the rule of thumb is like to gas them down until they're less than 100 systolic and then DL, whatever you want to do. Just make sure that you're not going to skyrocket them by sticking a blade in their mouth. So after induction, just like regular cases that you've been in before, you want to treat any hypotension, make sure they're still stable, make sure you didn't, completely tank them out. You're going to tape your tube, tape your eyes. A lot of stuff happens in this period. I know normal cases, it's, you induce them, you put them to sleep, and then you're making surgical incision in, 10 minutes, depending where you are. But in this case, there's a long period of time between induction when you put them to sleep and then before actual incision. So during that time, there's a lot of positioning, prepping, you're placing lines. All of that stuff is very low stimulation. You do not need a lot of gas, number one. Number two, if you do give them a lot of gas, you're constantly having to treat their blood pressure. And when you've got a million other things to do, like your TEE and your A-line or your central line, all this other stuff, you don't want to be messing with a blood pressure. So just keep them really light. They don't need a lot of gas at this point. Put on all the rest of your monitors, your BIS, your cerebral oximeter, place your central line. Again, I'm not going to go into details of that, but T-Berg, head to the left, use ultrasound, place your central line. If you're going to use a Swan-Ganz, now's the time that you would float that in. Once you float it in, take a second to write down exactly the depth of it, because later on you're going to be withdrawing it a little bit, and you want to know if ever there's an issue with your hemodynamics and you are wondering, well, I wonder if the position changed. If you know what the baseline depth of it is, you can know that the position's in the right spot. And then also write down your baseline hemodynamics, because again, if they're starting out with a really poor LV and really high pressures, then you can know to anticipate that, well, I just wanted to have this epi on standby, but now it looks like I'm probably going to need it. I'm going to go ahead and mix it up and get ready for it for a post-pump. So you can go ahead and set up all your lines. I think most people will use like your fluid warmer line and That's where you're going to give a lot of volume and blood replacement products. You can put that to the brown port of the cordis. And then most people use like a manifold to put all of your drips into the white port of the cordis, and again, or of the swan. However you choose to set up your lines, just make sure you know where everything's going. That's important because you are in an emergent situation. You want to know exactly which line you're going to be pushing through. And then every patient's going to get an antifibrinolytic, so go ahead and start your antifibrinolytic. You want that going in. Make sure your antibiotics are going in. So they're asleep, they're not really that deep, not a lot of stimulation. You've got your A line, you've got your central line, you've got your PA catheter. Now you can go ahead and drop a TEE down. And again, you're just looking for overall contractility and checking a quick peek at all their valves and making sure their aortic valve is doing well. And once they start positioning, that's the time that you want to take a pause, and just like any other case, whenever they tuck the arms, you want to stop what you're doing and make sure that your A-line is working, you have an adequate waveform, it's not dampened, because you're going to be here a while. This isn't one that you want to, kind of muck around with it. If it's like, I don't know, it's kind of positional, don't let it slide. Just take the time, okay, stop, untuck the arm, let's fix this, fix the problem, because once you're tucked and draped and the surgeon's working, and you don't have an A-line, that's a really bad situation. So take the time to do that. And then you're going to put up an ether screen. Has anybody seen me? Has anybody done a heart? Okay. You haven't. So you guys know what the ether screen is? It's like little brackets on the side of the bed, and then the ether screen itself is like this metal U-shaped bar, I guess, and you set it in the little brackets, you tighten the brackets, and then whenever they give you the drapes, you're just going to take the drapes and fold it over the ether screen and kind of shove it in underneath so you can still see the patient. So get your ether screen, take your drapes, put that in. Are your antibiotics in? So you should have drawn a baseline ABG as well after your A-line. I forgot to mention that. So at this point now, your baseline ABG and ACT has come back. You want to know what your baseline ACT is. You also want to treat any abnormalities with your ABG. You want to start out on the right foot. The main goal in this pre-bypass period is just to keep them stable. Just keep them where they live, keep them nice and happy. You don't want hypertension, you don't want hypotension, you just want to perfuse their organs and keep them status quo until you come off a pump. Another really good little tidbit here is whenever you have your drugs ready to go, like if you're used for a downer, you're using Cardine, and for an upper, you're using phenylephrine. You will hopefully have an opportunity to use both of those drugs in the pre-bypass period to see what the patient's response to that is going to be. Some people you give like a little whiff of it and they have a profound effect, and then vice versa. Some people you can like push half a stick in and like they barely move. So you want to know exactly what these drugs are going to do, and the pre-bypass period is a good time to trial run those so that you know exactly how it's going to affect them post-bypass. So throughout me talking, I'm going to like kind of say little trigger words, and when I point out like trigger words or trigger events, I want you to just like automatically associate that with something else. I think that really helped me a lot when I was a student, is when I think of one thing, I automatically think to do that. And when you're doing cardiac or you're doing these heart cases, there's a lot of instances where, oh, this just happened, trigger, I know I'm supposed to do this now. So there'll be a lot of things I'll point out like that. In the pre-bypass period, there's lots of varying degrees of stimulation. Adjust your anesthetic as needed. These patients don't need a lot of anesthetic when it's a light period of stimulation, and then vice versa when they're going to have intense stimulation. You want to make sure they're deep. Again, you don't want them getting tachycardic. That's going to increase the ischemia of their heart. You don't want that to happen. And there's constant, like I said, constant manipulation of the great vessels, constant compression of the heart. Just constantly communicate with your surgeon. This is not the kind of case where like you put the drapes up and then you don't see the surgeon to the end. There's a lot of communication. There's a lot of back and forth talking between the surgeon, between the anesthesia provider, between the perfusionist. There's just constant closed loop communication. Make sure everybody's communicating with each other. If you see a sudden drop in blood pressure, it's usually something that they're doing. So you can just say, hey, I got some hypotension. And they'll say, oh, whoops, sorry, I was leaning on the heart or whatever. So usually what you're seeing on your side of the drapes on the monitors is usually a direct reflection of exactly what they're doing on the other side. So just communicate that. Always know what the team is doing. Always know what the steps are of the surgical procedure, because there's a lot of things that you can do to facilitate that. And I'll point those out with like my little trigger words here. So you're induced, again, you're at a half a Mac, you're really light, you haven't done a whole lot except for all your induction stuff. The surgery hasn't really started yet, but you see the surgeon walk into the room. So there's a trigger event. The surgeon's been gone for the last hour. But now you see the surgeon, I know I need to get this patient deep because right now they're really light and he's about to come in here and make incision, and the last thing I want this patient doing is tacking away and getting hypertensive. So you see the surgeon come in, make sure you've got a good amount of narcotic on board, check your antibiotics. Are your antibiotics still going in? Check your antifibrinolytic, is that going in? Do they have enough muscle relaxant? Do they have enough narcotic? Because I want to blunt the sympathetic response to stimulation. So, okay, surgeon makes incision. The next big thing you're going to see in the sequence of events is sternal incision. And hopefully your surgeon communicates with you and says, like, hey, I'm about to, saw this person's chest open. But if they don't, you're going to know it because a very loud saw comes on, and you will absolutely hear that. So when you see a saw, or you hear a saw come on, you know he's about to make the sternal incision. Make sure they're paralyzed. Again, make sure they have narcotic. And a really big thing is you want to put the lungs down. I think most surgeons have pretty good communication with that. They're constantly telling you lungs up, lungs down, lungs up, lungs down. Just constantly reiterate, closed loop communication. But when you hear that saw, go ahead and flip the lungs down. You don't want them accidentally sawing into that. Here's another big trigger word. Whenever they saw the chest open, they're going to put these big sternal retractors on. I think I have a picture of it somewhere. Right here. So like this big metal square with a saw tooth. So they put these sternal retractors on and they spread the whole chest open. They want this really big surgical field. So if you think about this anatomically, a patient's lying like nice and supine, and then they retract this chest. So now they're like this. So when you think about positioning, number one, their head could potentially no longer be supported because now they're just kind of dangling. So trigger word, you see that retraction, check their head. Make sure their head is supported. You don't want this patient waking up paralyzed. You want to make sure their shoulders are supported. You want them waking up with a brachial plexus injury. You can also potentially extubate the patient with that kind of position changing. And then also they can potentially get something caught up in there, and you can have a sudden deterioration. So take a look at all your monitors, make sure everything's working. Did you suddenly have a massive drop in blood pressure? Communicate it if so. Whenever they're harvesting the lima, usually most surgeons will sit, so they'll sit and they'll say put the bed all the way down and tilt away so they can get over there to that side of the heart. And if you take a peek over at the drapes, you can look and you can see the lungs inflating and deflating, and they're working right there, and the lungs are kind of just pushing up against the hands. So here's another good trigger event in like the sequence of events. Whenever you see them dissecting the lima, just decrease your tidal volumes. That'll help them out. Some surgeons aren't picky, and you'll say like, hey, how's it looking? Do you want me to decrease the volumes a little bit? And sometimes they're like, no, it's fine. But other times, a lot of times they'll say, yeah, that'll really help. So it's not in the way so much. So just communicate, constant communication. Heparin. And make sure you know heparin, because by God, you'll use heparin. And know where it is, who gives it. Sometimes they give it in the surgical field. Sometimes anesthesia gives it. Know what the sequence of events is there at your facility. This is considered a sentinel event. This is one of those things where when he says to heparinize, I say he, she, whatever. We all know women are the leaders, so I'm just saying he because I'm thinking my own experience. So whenever the surgeon asks to give heparin, that's a sentinel event. Everybody stops what they're doing. You're going to repeat the order. You're going to give it through the central line. You're going to aspirate blood in the central line. Make sure that you're actually giving it. And then this is another big trigger word for you. When they heparinize, you know that they're getting close to cannulating the heart. And you can also see when the surgeon is making purse string sutures. So if you think of like a drawstring bag, a purse string suture is where they make a suture line going this way in a circle, and then a suture line going this way in a circle, and then they can cinch it tight, and that's the kind of sutures that they make to hold the cannula in place. So when you see them doing the purse string sutures and you hear them ask to give heparin, that's a trigger event because something is about to happen and there's something that you need to know to do. That means that the surgeon's getting close to cannulating. So whenever they cannulate, they're going to cannulate the arterial side first. This is it. Yeah, this is your aortic cannula. It's red in case you didn't know. I have a slide on this. By the way, the dose for heparin is 300 to 400, which is easy to remember because that's also what you want your ACT to be. So once you give the heparin, they're going to wait for the ACT. Once the ACT is adequate, they're going to be ready to place the aortic cannula. So think about this. If your blood pressure is 160 and they make a hole in the aortic root, you're going to shoot the ceiling. They don't want that to happen, obviously. So a rule of thumb is most surgeons want the blood pressure less than 100 before they shove this in an aorta. So when they say heparin, give heparin, you know in the next 3 to 5 minutes, you need that blood pressure less than 100. So heparin, trigger event, get my blood pressure down. So hopefully at this point you will have had a chance to give your nitro or your cardine or whatever you choose to use as a vasodilator to get the blood pressure down, so you'll know exactly how much to give. If you happen to miss this trigger event and now your ACT is good and he's ready to cannulate and the surgeon looks at the screen and they see the blood pressure is 160, he's going to look over at the drapes and he's going to be pretty pissed because now he's having to wait on you. So in an effort of, the pressure and everyone staring at you waiting, you're going to slam some whatever downer you slam, and now your blood pressure is going to be 40 because you weren't paying attention. So pay attention. So this is what the aortic cannula looks like. They put this into the aortic root and you'll just see it pulse up. And when it gets to the top, the surgeon will clamp it. They'll take the primed perfusionist tubing, they'll connect them, get the air bubbles out through this little port here, and then now all of a sudden the patient's arterial system is connected to the perfusionist machine. I'm not going to go into detail about perfusion because I don't know about it. And so when you hear the surgeon, so once they're connected, the surgeon's going to say, okay, go ahead and wrap it. Wrap it. That's a trigger word for you. When they say wrap it, they're taking about 100 to 300 mLs of the patient's arterial blood, and they're going to prime the perfusion machine with it. So this is important for you to know as a trigger word because your blood pressure is about to drop. So go ahead and treat it. And again, hopefully you will have used phenylephrine or ephedrine or whatever you choose to use to increase the blood pressure so you'll know exactly how much to give without overshooting it. Because you don't ever want to, you don't want it too low, you don't want it too high, you need to try and find that sweet spot. Here's that schematic of it. You can see all the different cannula there. So once they do the aorta, then they'll do the venous. This one's blue. And so once these cannula are in, they're connected to the perfusionist machine and they're getting really close to bypass. Yeah, we'll mess with that later. So like I said, the purse string, blah, blah, I told you all that. We're good there. So the perfusionists will start doing their thing. You'll know that they're getting close because they have like this really short, like narrow wheelie chairs, and they're like wheeling back and forth on these little chairs, and they're like doing all these Kelly clamps and like messing all their stuff and writing down all these like inflow, outflow numbers. And I really like watching perfusion. It just like looks really fun to do. I think I would like to do that if I did do anesthesia. It's just like the wheeling back and forth. So perfusion's getting their stuff, making sure that they're ready to go on bypass, making sure there's no kinks in their cannulas, making sure their pressures are good. We're checking to make sure that we have enough heparin on board. We want to make sure that ACT is 300 to 400 seconds. We can go ahead and get ready to go on bypass by withdrawing. If you have a swan, you want to pull it back out of the pulmonary artery. If you think about this anatomically, your heart is full of blood. It's pumping blood through the artery. Whenever you're on bypass, that is a bloodless field. Your pulmonary artery now is going to kind of collapse. And if you've got a catheter in there, you can potentially rupture that artery. So pull it back a few centimeters, get it out of the artery. You're going to go ahead and empty your pre-bypass urine, and then this is a good point to go ahead and give the rest. I think most people put like 10 cc's of Versa. Is that what you do? 10? Okay. Do you give, yeah, at least, is that what you said? At least. So then now you just give the rest of the 5 of Versa here. If you gave 5 up front, I'd give another 5 of Versa. I'll give another whole stick of rock, and make sure they have enough narcotic. Go ahead and turn off all your drips. Get your monitors ready to go on standby. Once everybody's ready, lots of closed-loop communication. Surgeon's going to be asking perfusion, are you ready? Anesthesia, are you ready? Blah, 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 blah. The perfusionist is going to slowly start to take over. So perfusion, the bypass machine is not all or nothing. It's not black and white. You don't have to be on full bypass. It's kind of a gradual process. So once they get onto full flow is kind of the word you're listening for when the surgeon says, okay, go on full flow. That's when you know that your job is kind of coming to an end at this point and you're kind of ending your pre-bypass period. So once they're on full flow, the perfusionist is taking over, they're oxygenating the blood, they're maintaining the map of the patient. You can go ahead and stop your ventilation and turn off your gas. Before you turn off your gas, take a few steps over, look at the perfusionist machine, and just make sure he has gas on, or he or she, whatever it is. Make sure that they have gas running, because the last thing you want to do is turn off your gas and them to have forgotten to put theirs on, and now the patient's not anesthetized, which again, this is why we have a BIS on. But this is kind of their induction period. A lot of things are happening for the perfusionists at this point, so I try not to bother them and ask them, just go look. It's 2 steps over. So once your vent is off, your agent's off, you've got all your drips off, they're on full flow, meaning there is no more blood pumping out of the LV anymore. There's no more blood going back into the heart. All your stuff you can put on standby. The perfusionist is going to go ahead and start cooling the patient. You want neuromyocardial protection, and then they're going to cross-clamp the aorta. So I think I have some hearts here. So if you've got your aortic root here, and I don't have clamps, but like your clamp is going to go here. And then if you think about your coronary os, they're down here, and that's going to perfuse the top of your myocardium, right? So they're going to cross-clamp this, which means no more blood is going through your coronary os, which means you're not perfusing the top of your myocardium anymore. So you will slowly see the heart die, basically. You'll look at your A line. Your A line is going to slowly lose its pulsatile flow. Your CVP is slowly going to drop, hopefully, if everything's working right, because no more preload is coming back into the RA. It's all going to your perfusionist. And your EKG will slowly arrest. And that's like the funnest part to me. It's just like watching like a patient code, but like not have to do anything about it. It's like, oh, I don't have to be worried about this. It's not my problem. Okay, cardioplegia. This was like the most difficult concept for me to understand when I was studying. I don't know why, but so they will use so have you guys read about like antegrade versus retrograde cardioplegia? I don't know why this like totally stumped me, but so they're gonna take the antegrade and they're gonna put it in the aortic root. And they're going to shove some potassium-rich cardioplegia in this. And they say antegrade because it's in the blood flow of how it normally goes, right? So this is why I said that we always look at a TEE and we always want to check for AI. And this is important because whenever you are perfusing your myocardium, it is in systole or diastole. Anybody know? It's diastole. So when you're in diastole, your aortic valve is closed. And all of the plegia this is closed. The plegia they're inserting is going to go through the os and it's going to go into your myocardium to perfuse all of that. So if you have a leaky valve, where's the plegia going to go? Right into the ventricle. I don't want plegia in the ventricle. That's not doing any good for us. We want it to go through the arteries. So if you have aortic insufficiency, that's going to change your anesthetic just a little bit. You got to do a few more things. So they'll still do antegrade plegia, but then they'll also going to do retrograde plegia. And it looks the same as this one. So I think this is it. Yeah, retrograde. So they're going to use retrograde. On the back of the heart is the coronary sinus. I don't think this is like an actual schematic of it, so this one doesn't show it. I have a slide. Okay, so on the back of the heart, you see the coronary sinus. That is the venous system, so it is valveless. So you can inject the plegia, and it can kind of work in reverse and go retrograde, meaning against the flow of blood, so that that part of the myocardium is still getting the plegia, and you're still arresting that part of the myocardium so that you have some protection there. So what you need to know is if they have AI, number one, they're going to use retrograde plegia, and that's important because they have to get to the back of the heart to get to the sinus to put this vent in place. When they pick up the heart and they're flipping it all upside down, left and right, and squeezing it all over the place, what do you think is going to happen to your blood pressure? So you're going to have a lot more vasopressors ready to go. And then this is the really annoying part. You need like a whole second transducer because they transduce the coronary sinus because obviously they don't want to rupture it with too high of a pressure by injecting too much cardioplegia. So when you have AI, you're going to do retrograde. You're going to use more vasopressors. They're going to be a little bit more unstable during that period. And then you're also going to want a whole second transducer. So once you're on full flow, you're on bypass, you gave your drugs, your job is like done. Not really. I mean, you still have to stay in the room usually, but well, at Baptist you don't. So that's like a good breakfast break or whatever. So when they're on bypass, there's constant monitoring. They're going to constantly monitor the EKG. You want isoelectricity. You want an isoelectric heart. You want no electromechanical activity for the heart because you want it to have as much protection as possible. So the more it's working, the more oxygen it's consuming, and that's not what you want. So they're going to constantly be giving plegia. You're constantly monitoring the map. The perfusionist is the one who's kind of taking over this role. They're going to be giving whatever pressors they need to maintain perfusion to all the vital organs, maintaining the temperature, maintaining urine outputs, keeping an eye on that. I think usually they'll draw Q 30-minute ABGs. They'll be fixing whatever electrolyte abnormalities, redrawing ACTs, giving heparin as needed. Excuse me. Any drugs are going to be given through the perfusionist at this point. Quick little overview on the surgical procedures. If you do a CABG, you're anastomosing areas of blockage. A pimp question I got when I was a student is, do they sew the grafts proximally first or distally first? Does anybody know? Distally. And the reason for that is so that they can go ahead and inject plesia to the parts past the stenosed areas, so that that area of the myocardium can gain some protection from the plesia. So once they're done, they'll do the distal first, they'll inject the plesia, then they'll do the proximal, and then they'll start to rewarm, remove the clamp. Fresh blood will wash out the plesia through the coronary arteries, and you'll slowly initiate the weaning from bypass. If you're doing an aorta, they're going to cross-clamp the aorta, and they're going to actually open up the aortic root. They're going to make an aortotomy. So a lot of air is going to get in the heart. So the difference in anesthetic implication between a valve and a CABG is you have one extra step. You'll have to de-air the heart. And if you've never seen a valve placed in surgically, it's really fun to watch over the drapes because it looks like they're not doing arts and crafts over there, like cross-stitching, because there's like 75 different sutures. But so they'll do the valve, they'll sew it in place. Once the valve is in place and they're confident about its surgical repair, they'll start to rewarm the heart, or they'll start to rewarm, and then they'll have to de-air the heart. So when they de-air the heart, they're going to irrigate it, get all the debris out. They're going to take the LV vent, which I don't think I showed you that yet. This goes in through the superior pulmonary vein through the LA and through the LV, and it helps vent the air from the LV so that the heart does not refill with blood and so you don't have any air. So whenever they're de-airing the heart, they'll get all of that out, they'll shake it all out, they'll aspirate as much air as they can, and then the final de-airing is our responsibility. So this is a trigger with, if they say, okay, go ahead and de-air the heart, what they want you to do is put them in T-Berg, and then with your right hand, you're going to give big Valsalva breaths, and then with your left hand, you're going to take your bed controls, and you're going to go left to right, Valsalva, left to right, and while you're doing that, the surgeon's going to be like shaking the chest and like getting all the air to come out. It's kind of a fun job. I like that part. It's fun. You can also turn your TEE back on, and you can look and see if you have any bubbles left over there as well. MVR, basically the same, except they're going in through the atrium rather than the aortic root. If you were doing a combined CABG and valve, they're going to do the CABG first, again, like we said, so that they can sew the distal grafts first and they can protect that part of the myocardium, and then they'll do the valve. So the de-airing will be like the final thing you do. If the patient's having redo cardiac surgery, this should be a big red flag for you, that this patient has the potential to be a lot more unstable than a regular heart. They've already had their chest opened, and the risk of hemorrhaging and the risk of crashing onto bypass is much greater. Whenever you do a heart and they close the sternum, the myocardium is basically right up underneath the underside of the sternum. So whenever they saw into the chest, there is a big risk for the adherence of any part of the myocardium, any of the grafts, any of the great vessels being right there underneath the sternum. And when they make this sternotomy, chaos can happen if they accidentally go through the heart or if they rip one of the arterial grafts or whatever. So there's a high risk of having to crash onto bypass in this instance. So you want to have blood in the room, and this is one where you want to probably have your drips pre-mixed, ready to go. All right, so your surgical side is done. They fixed it, whatever it was that was wrong with the heart. We're going to start initiating from bypass now. This is a good little mnemonic for you to remember, your CBPs, and use this as a checklist. Like, write it in your notebook, whatever, and when you're doing a heart, literally go through each one and check it and make sure that you're doing every single one. So when you're weaning from bypass, there's lots of things you're wanting to check, and the main goal is to get them back to where they were before you killed their heart. So the C's, the temp is going to slowly start to be rewarmed. You're going to want to make sure that they have a heart rate back, obviously. The surgeon may put in epicardial wires, and it's like a little thing like this big of metal, and then you've got a blue wire and then orange wires. So those are the pacing wires when you see them putting that in, and then they'll screw on little terminals to you, and then they're going to throw them over the drapes for you. Number one, put gloves on, that's gross. And number two, don't just let them dangle over the drapes like that. I had a case where I was a student and I was doing a heart, and the surgeon threw the terminals at me, and I was like, I don't have gloves on. They don't need to be paced anyway. Their heart rate's great on their own. So I just left them there. I don't need them. And a few minutes later, I hear him screaming profanities. And I'm like expecting like blood shooting the ceiling or like something crazy happening. And I'm looking over the drapes and I have no idea what's going on. We're all like staring at each other like, what is this problem? Like, what's going on? Apparently, somehow they got pulled back into the surgical field, the pacer terminals. So I didn't earn any brownie points that day. So whenever they throw you the terminals, plug them into your pacer. Even if you're not using them, just plug them in so that doesn't happen to you. Contractility, there's another C for you. You can use the TEE. You can also just look right over the field, just take a peek over the chest, and you can see the overall squeeze of the heart. If it looks pretty floppy, you know to go ahead and add an inotrope. You don't have to wait for anything else to happen. Just go ahead and start it. Cells, you're going to start giving back all of their autologous blood. If they had cell saver, all the blood from the perfusionist machine, you're going to start giving back all your blood. If your institution uses a tag, you can run a tag so you can have more specific information of exactly what kind of blood products this patient may need. Replace any calcium, coagulation, we'll talk about that next slide. The V's, ventilation. So once the perfusionist stops taking the venous return and they're giving it back to the heart now, they are no longer oxygenating the blood. So now you need to take over ventilation. Whenever you ventilate for the first time, go ahead and do a manual inflation. You want to keep your peak pressures less than 30. They just put a whole, especially if they're doing, if they did a cabbage. They just did a whole bunch of grafts. You don't want to blow increase this intrathoracic pressure and blow any of these grafts. That would be a bad day for you. And take over the ventilation and turn on your vaporizer. Again, anytime you're turning on and off the ventilator when you're going on bypass and off bypass, communicate with the perfusionist and make sure that this patient always has anesthesia. You do not want this patient aware. But what's going on at this point of the surgery? Not a whole lot of stimulation. They don't need a whole lot of anesthesia, especially coming off of pump. If they're a little unstable to begin with, the last thing you want to do is blow them up with a 1.5 Mach of gas, because then you're going to kind of you're not going to know where the issue is. Is the issue because they have too much anesthesia, or is the issue a surgical issue? What else? Volume expanders. Once you've given all the blood back, if they still need some more preload, you can give some crystalloids or some albumin, hex starch, whatever you guys use. P, all the P's. So the predictors for adverse outcomes. These were all the things we talked about in pre-op. What was their pre-op EF? Did they have a really low EF coming in? Then you can expect a pretty low EF coming off of pump. The longer the pump run is, there's something good for you. That's like the amount of minutes that they spent on bypass. The longer the pump run, the harder it's going to be coming off pump, the more pressors you may need. If it was emergency surgery, obviously they're going to be more complicated as well. You can re-zero all of your pressure lines, have your pressors ready to go, support their blood pressure with whatever is needed. If they're having if they're having any kind of dysrhythmias, you can give some antiarrhythmics. Pacer, again, have it available. Make sure it has batteries. Make sure you know how to use it. Potassium, you're going to replace any potassium. You want to make sure that those levels are normal with your ABGs. And then protamine. This is like a huge word in the cardiac room. In fact, at Flagler, it's like a 4-letter word. Like, students literally are not to... Is it still the case? Has anybody done a heart at Flagler? No? Okay. When I was there, it was like, you are not allowed to even say the word protamine. I mean, they like drill it in your head. Like, you are a student and you do not say the word protamine in this room. Like, it is a big deal. If you give protamine at the wrong time, it is a deathly mistake. Do not ever give protamine until everybody is in communication and everybody knows that we are giving protamine. Very important. Here's a little visual with a bunch of words if you like that kind of thing. Okay, here's another trigger. Chest is closed. That's a big trigger word for you. Whenever they're closing up, they're finishing up, closing up shop, they're going to take these big sternal wires and they're going to lift the patient up and close their sternum. Once the chest is completely closed, that's going to change your intrathoracic pressures. So this is a big time in the case where the patient can deteriorate. They can tamponade. You can kink off one of the grafts that they just did. You can impair the venous return, impair the contractility. A lot of things can happen at this point. So hopefully you have good communication with your surgeon and they'll tell you, hey, chest is closed. And they're telling you that not because they want to tell you exactly what they're doing. They're telling you that because that's important for you to pay attention to, because something bad can happen. And if it does, you need to communicate that. You can use a TEE. If there is any kind of deterioration, you can turn your TEE back on really fast and give a quick overview, see if you can diagnose what the problem is before they reopen. Some patients just can't tolerate chest closure, especially if it's an emergent situation. It's a very poorly compensated patient, and they just can't tolerate it. Some patients, I remember when I was a CVIC nurse, they would send them up to the unit with the chest open and just a film of Ioban over it. It's happened. All right, the case is done. Now you got to get ready for transport. This is the fun part. Fix your spaghetti so that your nursing colleagues love you and so that you are the competent provider that you are. Make sure you never disrupt your monitoring. I know at the end of a normal case, you can kind of pull off your EKG leads when, they're pulling the drapes down and stuff like that. This isn't one of those cases you want to do that. You want to overlap your monitors. So when the nurse wheels in the bed for you, take the transport monitors, put those on, get their pressure line, re-zero your A-line there, and then take off your anesthesia monitors. Always travel with emergency drugs. That goes without saying. The last thing you want to do is go up to the CVICU and plug up your monitor and see that your blood pressure is 170 when they have these freshly sewn grafts on. You don't want a high blood pressure with these new grafts. You want to keep them right in this, happy sweet zone. So once you get up to the CVICU, you want to establish patient care first. I know a lot of times when we get to the PACU, there's only a few lines to set up, and then you're like, okay, they got this and this and this and this and that. Okay, any questions? Okay, bye. It's not like that for a heart. There's obviously a lot of stuff going on. The patient's got a swan. They've got chest tubes. They've got Foleys. They've got this. They've got that. So you want to do all of your patient care first. The first thing you're going to do is pass off reports to the respiratory therapist, let them take over the ventilation, give them their vent settings. The nurses are going to be plugging up your chest tube to suction. They're going to be emptying the Foley. If you need to make any adjustments to the patient's hemodynamics or to their blood pressure or whatever, you're going to stand there and you're going to take care of the patient. Make sure the patient is stable. Once everything is connected and you have the nurse's full undivided attention, that's when you can go ahead and give your sequential report. Typical report. You guys know how to do that. I'm not going to tell you how to do that. And after that, you can just, pat yourself on the back because you just did a heart, and that's it. And I really mean this with every ounce of my being.
I have a question.
Oh God.
Can you talk about the TEEs, because it seems like you do it pre-induction.
So you're going to keep the probe in. After you go to sleep, you're going to put the TEE probe in, and you're going to do a quick overview for contractility, take a look at your valves, and check and make sure that your aortic valve is good. So then once you're done, a lot of times the surgeon will step in for that too, and they'll say, hey, give me this view, and then you can manipulate it to give them whatever view that they're looking for, because they're wanting to see what part of the heart is lacking squeeze and what issues that they're having specifically. And then you're going to turn the light off. You never leave the light of your TEE probe on. You're going to turn the light off, turn the machine off, but you're going to keep the probe in place, because at any point they can say, hey, give me this view. And the surgeons, you're standing here on the drapes, the surgeon's right here, and then the TEE is right there. So it's like a direct vision. So they'll say, hey, turn on the probe and give me this view. And then they'll, okay, and go back to it. And same thing at the end, when you're coming off the pump, they'll say, hey, turn on the TEE, let me see what it's doing. So they're seeing the outside of the heart, and then you can get a little bit more information when you're looking at the TEE too.
So the surgeon is the one interpreting the TEE, and we are...
It's collaborative. Yeah. So, yeah, it's collaborative.
Talk about some of the ways. So, I remember when I was in school, I didn't even have a lecture on TEEs, and I just went in the heart room, and then I did 3 heart rotations, and then I just did on-the-job training.
Yeah.
But you don't have the luxury of that probably this time. So talk about some of the things that you did either in your ICU training or in school, and then right after you entered into practice that helped you be better prepared to just
for TEEs.
Say, all right, I'll show you the 4-chamber view, or how to
So, just anytime you're ever in clinical, just always advocate and express interest. A lot of times it's really all you need to do is express interest and say, hey, can you show me how to do this, or do you mind if I do that? And a lot of times, especially if you have a nice cardiac surgeon or a nice, whoever you're working with, an anesthesiologist, whatever, then they'll hopefully take the time to show it to you. But YouTube's a really awesome resource for you. That's really it. Just on the job, asking people to show you and being vocal enough to try to seek out those kinds of opportunities. Whenever, even now to this day, when I'm doing anesthesia for TEEs, and they're, especially if they have fellows or residents, the cardiologists, I'm always listening to what they're saying. I'm like, hey, what is that? Can you explain that? And just ask questions. But a lot of times, these people like to talk, so they'll tell you what they know.
There's a couple like 4 like basic things, right? Like the first is make sure it's in the esophagus. Awesome, right? Then depth. So there's 4 main views you'll always look at, right? So if you can associate shallow versus deep somewhere in the middle, and then look and pay attention to see the angle of the transducer. You guys get this in your TTE and TE lecture in a couple weeks. Those are the key things that if someone left you alone, you know that like the LV view will be the deepest, the 4-chamber view will be somewhere in the middle, and then when you want to look at the LV, you'll probably turn it this way. And you want to look at the RV, you'll probably turn it this way, right side of the heart, left side of the heart. And those basic things are just the beginning steps for you to be able to it's not 90 degrees, it's 30 degrees. And for everybody, your perception of that will be different. But until you put your hands on it, in the beginning, it's observing the fellow. Mm-hmm. It's observing the 70-year-old should-be retired cardiologist who comes in and does the TEEs in the OR for a diagnostic one, and you're just doing the anesthesia as a TIVA, for instance. Watch the basic things. Depth, what do they do to turn, and then what is the angle of the transducer. Forget about the color flow, all that other stuff. Just get to the right view first. Everything else will come after that. So the physical skills first, technical and comprehensive skills of how to interpret what you're seeing come through experience. If you can't even do the first part, after about 10 seconds of you fumbling around, they'll say, call your anesthesiologist.
Mm-hmm. That's not my level of expertise. They ask, the anesthesiologist is like, so, Christine, can you tell me what you're looking at right now? I'm like, that's the heart. That was my answer. The answer was suffice to the right student. They're like, you are absolutely right. That is a heart. I'm like, great. Next question. Any other questions?
Line placement. So that's another, I think, at their stage, that'll probably be a good, big barrier, mentally wrap your head around. So everyone else goes in the IJ. Have you done any subclavians?
Yeah, so I think I mentioned you can get a central line wherever you can get a central line, but obviously there's always going to be implications of exactly where you're placing it and what kind of implications it's going to have. So you can put it in the left subclavian. That's really great for long-term use. It's obviously more technically difficult. You have a higher risk of lung injury over there. And then also you have a risk of whenever they have the sternal retractors in place and they're over there manipulating, you can obstruct the line over there, and then you're going to have to tell the surgeon, hey, whatever you're doing, you need to stop, because I don't have a line.
Also, they can think they're near the lima, but they're not. And then they saw through the subclavian vein, and propofol starts leaking into the surgical field.
That's not fun.
And then they expect it to be in the IJ, and for whatever reason you said, I had a case where I tried to do IJ and it wasn't working. So 4%. We used a subclavian. We did it on the left because that's the easiest one to do. Mm-hmm. And then they were doing a lima graft, and we didn't tell them, no big deal, and just boving out the yin yang like this, and then all of a sudden it was a milky red chocolate. And, the number of expletives that came as a result of that, because he wouldn't expect it there, and he saw it literally right through the line.
Oh.
So it was not usable anymore. Mm-hmm. So in the middle of the case, you had to put a femoral under the drapes in, and then pull a line out, do it without a swan when they expect it to be a swan. So getting back to Dr. Wilson's point about circular communication, every detail actually matters. Mm-hmm. Also think about it, if they're going to take a radial, don't put the A-line in the radial. It seems common sense, but a lot of times you just get so focused on where this side's going to need this. Mm-hmm. You just get in the habit of I'm on this side, I'm going to go to this side. So, but everything you do, think it through. Why are you doing it? Why are you doing it there? What kind of implications is this going to cause? Nothing we do is benign. Always know how it's going to impact you going forward. I would say probably the other really good point that she brought up was that the test bed of your uppers and downers in the pre-bypass period is, you don't even think about doing it now. You just wait until it's hypotensive and you try. But even when they're, they're stable, a smaller half or quarter dose of what you normally get would just tell you hyper response, normal response, or hypo response. Mm-hmm. And that gives you an idea, because you don't have time to wait 2 to 3 minutes to get the right dose. It's got to be the right dose the first time when you're coming off of bypass. Mm-hmm.
Or whenever the surgeon's staring at you like you're an idiot and like you feel that pressure and like, you know, the eyes are just boring into you and you're like, shit, and you just like push a whole syringe and then you're like, that was stupid. Now I just bit myself in the ass.
And then, like, to your point also, like, there'll be times where the blood pressure will be low, and like, they're hypotensive, and the surgeon's thinking, like, yeah, you ding dong, of course it is, I've just turned the heart over, I need to do this. Give me 20 seconds.
But if you're communicating with them, they're usually going to communicate with you. So if you keep saying, hey, I've got some sudden hypotension, and they'll say, oh, yeah, well, I was just doing this. So now next time the surgeon goes to do that, they're going to say, hey, I'm about to lift up the heart. So then you can already know, okay, let me just go ahead and treat it because I know it's about to drop. So communication, 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 communication.
Or if it's something short, like, they're just looking.
Yeah.
They're just going to look for a second. They're like, I'm looking for a second. You're not pushing 500 mics of
right.
to treat something.
But you're not going to know that unless they communicate that with you. So the more you communicate with them, the more they're going to communicate with you. The better it's going to be, the smoother it's going to be, the less chasing of your tail you're going to have. It's just going to go a lot smoother. Any questions? You guys can come and touch and feel. So yeah, show and tell. So
very nice show and tell.
Thank you. Y'all, you don't know how proud I am that I remember this. I legit almost forgot it a second time. Even though he texted me and was like, don't forget. I'm like, no, man, I got it. But then...
Not possible.
Nope, not possible. So you guys can, like, come up. I showered today, so you can come up.
Except for Tampa. You have to do a little show and tell.
Oh, okay. So where's the camera in front of me? So this is a schematic of the aortic valve, and you can see it's really squishy, so it's really a fun thing to touch. I have so many jokes for this, but so here's a healthy one. Here is a diseased one, and then here's like a little spinny wheel. Here you go. You can spin around and look and see what a normal valve looks like, what a mildly sclerosed valve, and then a severely sclerosed valve. We didn't talk about vascular at all, but here's endovascular stents. Here, same thing, we didn't talk about TAVRs either, but here is a schematic of a TAVR. And I want to say, yeah, this really heavy thing that I had to carry in is also for a mitral valve repair with a mitral clip. We didn't talk about any kind of structural heart stuff, but this is all up here for you guys to look at. And again, we didn't talk about Watchman, but here's, they had it, so I took it, and here you go. Here's valves. I have actual valves here. I didn't open it because I don't really want to smell it, but if you guys want to come up here and do that, you can. I don't think I have any mitrals, though. I think they're all aortics. The only mitral valve I have is a mechanical one, and I don't know why this is, like, so cool to me, but, like, it's like a mechanical valve.
It clicks.
Huh?
It clicks.
Yeah, it's pretty cool. And then here's a ring for whenever they repair it. They're just going to sew that around the mitral valve. And this is a structural heart that shows you when they're doing a TAVR how they go in. And they use this balloon to deploy the actual valve.
$95,000 in 5 seconds.
Crazy. Better hope it's right. I mean, you guys can come up here if you want.
All right. Begin the show and tell. No other questions?
Touch and feel. Any questions, concerns?
All right. Thank you very much.
Thank you.
This call has been disconnected. Thank you for joining.